Good evening, everyone. We welcome you all to OrthoTV online original webinar series. Today we have with us my very good friend and an eminent knee replacement surgeon from Mumbai, Dr. Vivek Allahabadia. He's attached to Hinduja Healthcare Hospital and Raheja Hospital in Mumbai. He is going to talk to us on navigation and robotic assisted total knee replacement and his thoughts about it. So over to you, Dr. Vivek.
Thank you, Neeraj, for the generous introduction. Uh, I've been practicing in Mumbai since 1995, and I have been using navigation for more than 14 years. And I've been following technology for knee replacement very, very closely. And recently, a lot of things have changed by a huge margin. And since I was researching the topic and Neeraj approached me, I thought, yes, I can make a lecture about what I have been following and what I am deciphering about what's happening in the world with the advent of navigation and robotic and how surgeons are changing their trends of how they perform knee replacement. So these are my thoughts. You all are free to send in comments later if you all want. So with the advent of navigation, the prime interest was to get alignment right with little emphasis on limiting soft tissue releases. So we would do soft tissue releases like usual just to get a mechanical axis right with navigation. More than 3-degree variation has shown to increase prosthetic loosening from 3 to 24% in 8 years. The references are given. There are papers against it as well. Some say that if the joint is very well balanced in flexion and extension, the longevity does not get affected so much unless it's drastically out of variation is more than 7-8 degrees. So the aim in navigation was to get alignment within 3 degrees of normal. You could upsize components or flex and rotate femur to tighten flexion space and alter the flexion gap in the flexion gap. In PS knees, flexion space opens a little more than when you do a CR knee. So you could make these adjustments to balance your knees properly and make sure there's no mid-flexion instability. There should ideally be no mid-flexion instability for good results, irrespective of alignment, or patients are never happy. Navigation and robotics both give graphs showing ligament balance and tension throughout range of motion, warning against mid-flexion instability. No pre-op CT scans were needed in the image-free navigation systems that we were using and which were more popular. So lots of literature shows that navigation is not that useful and people quote it. But after doing navigation for more than 13 to 14 years, I realized that Indian bones are different and sometimes you can get caught out. Lot of people have long bone deformity, especially with increased varus deformities in India and who are osteoporotic. You often find bowing of long bones, which you miss out on small films. So I always prefer, while screening the patient pre-operatively, to do full-length X-rays. Navigation adjusts for the bowing in intra-articular cuts if not very severe to give a good alignment. So these are some X-rays if you see. The femur is markedly bowed, showing that the valgus angle needed to cut is 11 and the coronal and sagittal plane both can have bowing. So you should screen patients thoroughly if you get bowing or you suspect bowing. I routinely do full length X-rays now of all my patients. So what were the problems that we faced with navigation? There were small limitations. There was a play between the jig and the saw. Margin of error possible needing recuts. Saw skiving of sclerotic bone, again during verification would show that we are not there and would need to recut the bone. Still possibility of seeing slightly more outliers in navigation compared to robotic surgery. Active robots with milling systems are so accurate in cuts that you can dial in 2 degrees of varus cuts to avoid medial release, which is being done routinely nowadays in kinematic alignment to avoid soft tissue releases. In navigation, 2 degrees can sometimes become 4 or more degrees if you recut. So according to me, there are some weaknesses in navigation. One is inaccurate. One of the things is inaccurate marking of landmarks by inexperienced surgeons. So what we call garbage in, garbage out. And the saw as a cutting tool compared to the 6-axis robots using milling tools, there is no comparison. Another drawback is that navigation has a long learning curve. So the surgeons take a lot of extra time initially. As they do more cases, the operative time comes to nearly that of normal, maybe 5 minutes more. Ligament releases done mostly as per non-navigated cases in majority of the case. Still, kinematic alignment started gaining popularity, and people started modifying femoral and tibial cuts, as we will see as the lecture goes on. So robotic knee replacements are now the in thing in centers or surgeons who can afford it. So smaller incisions combined with greater surgical precision means that less bone and tissue is disturbed, speeding up the body's natural healing process. More emphasis on modifying bone cuts to minimize soft tissue releases. With 6-axis robots with milling tool, less retraction needed. Knee doesn't even need to be dislocated anteriorly. Patella needs not be everted but can be pushed to the side. Femur rotation is changed to minimize ligament releases. Tibial cuts in varus to reduce medial releases. Pre-operative CT scans are needed in most robotic knee systems. It eliminates outliers more efficiently than navigation or conventional surgery. Safety stops minimize soft tissue or vascular injuries. Manual resurfacing of patella still has to be done if you resurface patella. The term robot is derived from the Polish word robota, meaning forced labor, and describes a machine that carries out a variety of tasks automatically or with a minimum of extended impulse, especially one that is programmable. So there are two main types of robotic surgical systems, haptic and autonomous. Haptic or tactile systems allow the surgeons to use or drive the robot to perform the operation. This technology requires constant input by the surgeon for the procedure to proceed. In contrast, autonomous robotic systems require the surgeon to perform the approach and set up the machine. But once engaged, the robot completes the surgery without the surgeon's help. In some machines, you can even come on the pre-op day of visit and feed in the CT scan and do all your pre-operative planning so that when you go into the OT, you don't even waste 5 minutes. Although there are few reports of the outcome following a robotic assisted surgery, the limited short-term data suggests favorable results. Similar to other robotic technology, long-term studies need to be conducted to determine the surgical efficacy. So autonomous robotic systems, these offer a theoretical alternative to passive surgery systems. Autonomous systems complete the case without surgical assistance. While they are in use, the surgeon is in control of an emergency shut-off switch while the robot operates independently. Currently, autonomous systems are still under investigation for use in orthopedic surgery in various fields. The example of this is Robodoc from Curexo, which is now available in India. I think Merrill has launched it. So this is the haptic system where the surgeon is involved. So this is a saw-based system. All the data is fed in. There are no jigs, and the saw guides the surgeon. Now this is a Burr-based haptic system. Instead of a saw, a burr is being used. This also requires surgeon input. Now this is the autonomous 6-axis robot, which is going to really revolutionize surgery. So once the data has been fed in, you just sit with the remote control and the robot finishes all the cuts in 16 to 17 minutes. including the tibial plateau and the keel. It finalizes everything. Only patella has to be done manually. And this is now available in India, though it's expensive right now. So the milling has actually solved the problems that we faced during navigation, where we had to recut and we would go off sometimes. I've seen X-rays of navigated cases which are about 4 or 5 degrees malaligned as well. Robotic, it's largely impossible, especially the autonomous robot. What you dial in is done. So what has changed lately due to technology advancement? So the bane of TKR was usually discussed in all unhappy patients, that 20% patients were unhappy no matter what you do. And these are international figures. So what the surgeons want is to get the TKR results close to THR, satisfaction rate. And now a lot of surgeons who are actively using robots or navigation systems, they think that by giving kinematic alignment and no or limited soft tissue releases, they are sort of achieving it. Due to accuracy of bone cuts and ligament balancing using navigation and robotic surgery, surgeons are trying to move to day care or short stay arthroplasty. They are moving on to modifying bone cuts to minimize or eliminate soft tissue totally. Sensors are even predicting loading of various compartments by changing implant positions. Most surgeons who are well versed with navigation and robotics in the West are using technology moving towards kinematic alignment or restricted kinematic alignment, where they still try to maintain the axis within 3 degrees. So role of bone resection effect upon balancing. While majority of balancing is soft tissue in nature, tibial resection and coronal plane will affect soft tissues. Femoral rotation clearly affects soft tissue tension, especially in flexion. So what are the alignment methods currently going around the world? Mechanical alignment is still used by majority of the surgeons, especially who don't have access to robotics or navigation. So the fixed target 90 degrees to coronal mechanical axis, currently widely accepted method. Anatomical alignment, fixed target based on mean alignment values, 2 to 3 degree femoral valgus, tibial varus from mechanical axis. Kinematic alignment, this is the latest and being accepted widely now by a lot of robotic surgeons. Target varies for each patient based on anatomy. It's an emerging technology, but gaining popularity very quickly. Which is our current. So the classic mechanical alignment, Freeman Insal Ranawat, concept of appendicular cuts, equalized flexion extension gaps, components perpendicular to mechanical axis, need for soft tissue release and balancing, predictable outcomes, more reproducible, and all-weather technique works in all indications. Cut the tibia and femur at 0 degree to the mechanical axis in extension, rotate femoral component to be parallel to transepicondylar axis and tibia in flexion. Balance the soft tissues to create equal and symmetrical flexion and extension space. John Insala had a paper where he said even with meticulous attention, perfect soft tissue balance is not always achieved in TKA, Journal of Arthroplasty. So anatomic axis by Hungerford, he said measured resection technique, maintain joint line alignment and position, avoids the need to externally rotate the femur. Difficulties with reproducible tibial cuts. Kinematic alignment. They correct the arthritic deformity of the limb to the constitutional, that is the pre-arthritic alignment of the patient. Aims to restore natural tibiofemoral articulation, alignment, and soft tissue laxity. Most believe that kinematic alignment is more sympathetic even to patellofemoral forces. Femoral component is generally in more valgus and more internally rotated. On the tibial side, tibia is in more varus, thereby minimizing soft tissue releases. It's not just putting the tibia in a little varus. It aims to restore 3 axes of rotation. Transverse femoral axis about which the tibia flexes extends, Eckhoff axis. It is close to the TEA, but it's slightly different. Transverse femoral axis about which the patella flex and extend. It's a little superior and anterior to the Eckhoff axis. And the longitudinal axis about which tibia internally, externally rotates. So let's have a summary of the types of alignment by surgeons who are using it.
Mechanical, I think of as the more traditional install described perpendicular to the mechanical axis of the drop line from the center of the femoral head to the center of the knee to the center of the ankle. That's more considered the traditional, and I would call that mechanical. Anatomic, I think the credit goes to Krakow and Hungerford back in their 85 publications, talking about how they wanted to have the knee be functional and perpendicular to the ground in stance. And that meant that they cut their femur in about 9, their tibia in about 3. Kinematic, I think, is sort of an offshoot of that. And if you really listen to the true believers, it's based on 3 separate axes. One axis is designed to pass through the long axis of the femur if you drew a circle over both the medial and the lateral epicondyle. And if you drew a line through there, that is not quite the epicondylar axis. It's a different axis. It was just originally described by Eckhoff. The second axis is where the patella tracks relative to the femur, and that's a little anterior and a little bit more posterior, anterior and proximal compared to that original axis. But those 2 axes are parallel to each other. And the third axis they talk about is how the tibia relates to those 2, and that third axis is perpendicular to those. So the concept of a true kinematic alignment is that you go back to those axes and reestablish the knee where that is. And the credit goes to the thought that if you are establishing that true axis of what the knee was before the cartilage loss occurred, theoretically, you're going to have a better outcome than your just.
So there are 2 separate considerations. Let's see them. Andrew Spitzer.
Must make a distinction between overall hip, knee, ankle alignment, which as shown in the diagram may be valgus, neutral, or varus, and the orientation of the joint line as shown on the right. The most significant driver of hip, knee, ankle alignment in the osteoarthritic knee is probably wear of the cartilage, which then causes deformity. While traditional thinking suggests that the soft tissues on the concave side contract around the deformity, and those on the convex side stretch, in fact, there is no compelling evidence that soft tissues contract. Therefore, restoring the natural joint line alignment, a hallmark of kinematic and patient-specific alignment, should reestablish the soft tissue tension and balance within the patient's intact soft tissue envelope. In contrast, in the mechanical alignment approach, cutting each bone perpendicular to its mechanical axis, or rotating every femoral component a fixed degree, often creates asymmetry of the soft tissue envelope, necessitating releases to balance the knee. So in summary, the patient must make a distinction.
Now to complicate matters further, there is inverse kinematic alignment. So I think I'm confusing you all successfully.
Inverse kinematic alignment is a patient-specific alignment concept for TKA. The main feature is a patient-specific tibial resection or anatomical tibial resection parallel to the tibial joint line. The same amount of bone is resected on the medial tibia as on the lateral tibia. The so-called resurfacing of the tibia is done. Then, the femoral resections are done and adapted to balance the knee. No soft tissue releases are performed. And this is actually the inverse of kinematic alignment, where first the femur is resurfaced and the tibial resection is adapted to balance the knee. By starting with the tibia and performing an anatomical cut, the tibial joint line is restored to its native obliquity. This anatomical cut is done both for varus knees, neutral knees, and valgus knees. The rest of the operation is the same as a conventional ligament balancing technique, but you start off with a patient-specific tibial cut. And then the ligaments and soft tissue envelope are tensioned, and the femoral cuts, both in extension and flexion, are performed parallel to the tibial cut. By not performing soft tissue releases, the native overall limb alignment is found, and the knee biomechanics and kinematics are restored as physiological as possible. To balance the knee in flexion, by performing an anatomical tibial cut, The femoral component needs less external rotation in comparison to mechanical alignment. A more anatomical femoral position is reached, avoiding overstuffing of the lateral compartments and restoring the trochlear anatomy better. A 5 to 6 millimeter resection of bone is advised, according to the thickness of the tibial implant. The resection level is measured from the deepest point of the medial and lateral tibial plateau at the middle of each tibial condyle, usually around the posterior 2/3. Remaining cartilage should be taken into account. For example, if there is still full thickness cartilage on the lateral side, the resection should be 7 millimeters on the lateral side, 5 millimeters of bone and 2 millimeters of cartilage. And also bony wear should be taken into account. For example, in Aubert grade 3, when there is significant bony wear, cut less bone as a compensation for the bony wear. Inverse kinematic.
So let's see the workflow in navigation between mechanical alignment and kinematic alignment. So here you see the ligament balancing is done through bone cuts.
To put a knee in, and you do it with a measured resection. This is what it looks like. This is the screen you're looking at. So I showed you the screen before where you take the measurements from the knee. This is the screen that you actually make the changes. So this is what the screen looks like. We can adjust every parameter here. And if you look at a standard mechanical axis alignment here, neutral alignment on the tibia, neutral alignment on the femur, and with the measurements we've taken, we can see that our gaps are not balanced, right? Lateral gap 10.5, medial 6.5, lateral 9.5, medial 7. You're not getting that knee balance without starting to do releases. Kinematic, on the other hand, would be like a caliper technique. We balance to what the knee was. So we'll leave the knee at 5.5 degrees of varus. We'll make our cuts to just replace what's there. And we're closer, but once again, it's not exactly balanced. And so with our way of doing it, by making some adjustments, here we have a 4-degree varus on the tibia. We've made some adjustments here. We're not doing a purely calipered approach because we can change the rotation. We have all the data. We can change the anatomic axis. We can flex or extend the component, and we can put the numbers exactly where we want them. Once again, you're always going to end these cases with the knee perfectly balanced.
So they're trying to minimize or eliminate soft tissue releases totally by manipulating bone. So they are advocating cutting the tibia in as much as 4 degrees of varus and internally rotating the femur. So this is how the surgeons have now changed their trend of surgery once they get hang of robotic and navigation system and sensor and tensors in the joint.
So we're transitioning from the old-fashioned pure mechanical to the computer-aided or computer-assisted technology. So in the old days, the only thing we did was looking at mechanical alignment, and we had spacer blocks, static spacer blocks. Now with the mechanical alignment, we can get more refined and go to variations. We can go to neutral alignment, kinematic alignment, anatomic alignment. The gap balancing side, we no longer have only static values, but we have dynamic values throughout the range of motion through sophisticated tensiometers and contact load sensors. So every patient in my practice gets, I try to analyze all these 10 data set points. So 3 of them will be concerning the alignment before and after surgery. 2 of them will be concerning the gap space, again, before, I measure before and after the resection cuts. But now with the advent of electronics and sensors, we have also the ability to look at loads and the load derivatives, as well as some sophisticated tensiometers will give you a better understanding of the ligamentous tension. So that's a long way from the traditional, where you only had basically 3 markers out of 10, and that was qualitative and not quantitative.
So here are some outcomes, early outcomes of kinematic alignment.
Techniques such as kinematic alignment that's been popularized over the years. There's relatively few studies of this. Max Courtney, one of our doctors, and Guo Li, another doctor from Philadelphia, collaborated on this meta-analysis. And you can see from the plot here that overall the kinematic alignment studies did better than the conventional alignment or mechanical axis alignments. But there really weren't a lot of really good studies, and so we need to continue to build on this. So maybe it's time to adopt a new approach. And these are some of Mark's preliminary data. He's going to show you more data that's a little bit further along. But you start to see numbers along the bottom here, satisfied 97%, doing the activities you want 94%, meeting expectations 94%. So if we can do that for our patients, what orthopedic surgeon would not want to do this? And I had the opportunity to see some of this data a couple of years ago at the AUKUS meeting, and it's really fueled my excitement for this as a possibility. It would be something that we could really bring to our patients and give them better results. And the reaction across the world and now across the United States, where it's recently begun, has been very, very favorable. We need.
So
the techniques such as kinematic.
So let's see the techniques used in kinematic alignment. Let's see the discussions.
For you, it's not the same.
So it's similar but different. So my
Okay.
approach is I initially expose the tibia. It's very important to
Yeah,
remove
exactly.
in the varus knee the medial osteophytes off the tibia and the femur. Those are tend to be collateral. And then we cut the tibia anatomically.
Yeah.
And then I'll balance my knee off that. The next step is to make sure I remove menisci, posterior osteophytes, any tight posterior capsule. And then I determine my optimal femoral component position by using the ligament tensor. And we run that through a range of motion in two positions. So in the varus knee, we let it sit where it sits. So if it sits, say, naturally in 8 degrees of varus, I'll run it through an 8 degrees of varus, which will tension the lateral side of the knee. I will then determine the correctability of my deformity. This is prior to the tibial cut. If I get my 8, say, back to 1, that's the correctability, probably the pre-arthritic alignment. Then I'll run through it at 1. So they'll then give me a balance curve. And then I'll manipulate my balance curve. My tibia, I rarely cut, recut probably 1% of the time. So I'm using my femur, I'm positioning my femur to balance my knee. The first thing I do is determine the optimal femoral component size. The BrainLab 3 system uses the AP, so diameter of the femur, which can tend to undersize it sometimes. So then I actually get a 4-in-1 cutting block, put on the end and get the optimal ML. So if I can upsize, I will. Then I rotate the femoral component. My philosophy is to have slightly more lateral laxity and flexion, so I have a mil more. It's hard to measure it because the system measures coronal laxity, not sagittal laxity that we build on. So then I'll rotate my femur. I'll then balance my extension gap to have a balanced gap. I like to have it perfectly balanced, but I will accept up to 1 millimeter of lateral laxity. I don't like to have any medial laxity. And then I'll look at my overall alignment. So I don't want my overall mechanical axis to be more than 3. So I've cut my tibia at 3. I'm not going to put my femur in varus, but if I haven't, I'll give a bit of movement there. So then I've rotated my femur for my flexion gap. I've altered my distal femoral cut for my extension gap. So the important thing about that is they are not predetermined, they're patient specific. So my distal femoral cut and my femoral rotation cut are patient specific.
So Thomas, Aubert, France,
You do a
let's hear
soft tissue
his
release.
views.
So hardly ever, because we think that with this technique, we want to avoid any release. That's the main thing, it's preserve the soft tissue balance. And I'm quite sure that after when we plan all the cuts, if it's possible to stabilize the knees without going beyond our limits, we are performing the surgery without any release. But some of the time, after your just laxity graph with the BrainLab system, if we see that we need to go beyond these limits, put more than 5 degrees of deformity at the end of the surgery, we are performing a release, step by step, the minimal release, the ligament release, and we are doing between every step, we are performing a new laxity graph, and if it's enough to perform the surgery with our limits, we're doing the release. But the thing is that it's never more than a picrostic release, never more.
Yeah.
So, and it's probably less than 5% of our practice.
Sure. You do a soft tissue release.
So,
let's see the early results by Andrew Spitzer.
In particular, this classic study by Dossett compared mechanically aligned to kinematically aligned total knees. The kinematic group at 2 years had better patient-reported outcomes than the mechanically aligned cohort. Importantly, though, there was no significant difference in the hip-knee ankle angle between the groups, though the kinematically aligned group had 2 degrees of more varus in the joint line than the mechanically aligned group, probably by intention. So how
What I'm going to present you today is our patient outcome satisfaction study with 2 and 5 year data. We have a very good registry in New Zealand, and I've used this to compare this technique. The first study is conventional measured resection return versus this technique. The second study is a 6-month and 5-year PSA churn versus other total knees in our registry. The holy grail of knee replacement surgeons is to be as good as hip surgeons, or maybe uni surgeons. We've looked at this with both 6 and 5 year data. I was an early evaluator of the churn. We had a number of patients. I did 100 patients. We looked at the 27 who had quite a lot of varus. We put it neutral and compared them with the first 41 we used this technique on. We were in varus, we left in varus. And finally, I'm going to show our variable rotation outcome study. There is orthopedic folklore that thou shalt not internally rotate the femur, and I'll show you with this technique this is incorrect. So here's our outcome data. So 956 cases pre-op, 520 at 2 years, 82 at 5 years. And what surprised me is the increase between 5 and 2 years. For those of you familiar with the forgotten joint score, in my opinion, this is the best score. It's the most discerning. Patients can start with 0, quite a few do, and get to 100 with a perfect knee. So we've got a very high scores both at 2 years and 5 years of 67 and 79. Cruise 12, 83, 89. Womack 9 and 7. Oxford 43, 45. Patient satisfaction, we asked the patient to rate how satisfied they are. 0, completely unsatisfied. 100, completely satisfied. 90 at 2 years, 94 at 5. We asked them to rate how normal their knee feels. 0, completely abnormal. 100, 100% normal. 81 at 2 years, 88 at 5 years. Pain, 70 out of 100 goes down to 12 at 2 years, 6 at 5 years. Andy showed you my 2-year data on patient satisfaction, and we do quite a deep dive into this. And here's the 5-year data. So if you ask the patient how adequately did they relieve are they satisfied with how it relieved their pain? 97.1%. Their ability to perform the activities they wish to perform? 96.8%. The ability to work and play sport? 84.6%. And meeting patient expectation? 96.5%. And 96% would have the operation again. So if we look at satisfaction here, which has been stuck in the 80% for 30 years, despite billions of dollars being spent on trying to improve the implants, it's certainly, in my opinion, that over time, we've just tried to put in every knee the same, and as every knee is different, it's no surprise about 20% don't go too well. But if we do put them where they want to be, they do better. You're never going to get 100% satisfaction. There's a whole lot of factors outside their knee that make people happy.
So the early results from New Zealand, 2 and 5 year results are just brilliant. Then there are some cases where they don't advise kinematic alignment.
We should be a little bit more open-minded about it. Yeah, and I really found that. So I started asking patients in the pre-op holding area. I would mark down what their range of motion was, and then I would ask them, "Have you always been bow-legged if they were a varus knee or knock-kneed?" And if the answer was yes, then I thought, you know what, I'm going to start to cheat these a little bit more into keeping the tibial component and some varus or a little bit of valgus. And what I found was that I started doing it more and more, and then maybe I overshot it by doing it on all patients who are varus or valgus. And I think there's a difference between those that have always been that way and the patient who has a meniscus tear 5 years ago, but prior to that, they had a straight mechanical neutral alignment. And those, I don't think that I should be putting into varus or valgus. I think those that have a meniscus that changes their alignment over time is not the same because their soft tissue envelope has been altered by their injury, not by their genetic predisposition. So what I found is sort of 25% of those in varus, 20 to 30% are probably always been a little bit bow-legged, and it's usually the spouse that brings it up. It's not usually the patient
That's
who
true.
brings it up. Yeah, I find that we should be able to.
Yeah, we've done a number of studies. We're lucky in New Zealand to have a joint registry, which we've had since 1999. And I think that the best thing about that, we started collecting Oxford scores. So the first study we did was look at the original tunes, and we've got 760 done conventionally. So measured resection, neutral alignment, manual, compared them with 362 using this technique. And what we showed was a significant improvement in outcome score. We also got 2.5 points, but the big difference was we had a third of the number of poor scores. And I think that's what we're all after, is to reduce the number of poor scores. We've then expanded that study and compared it with the average hip and the average knee in New Zealand. And again, this is 6-month data. And what has been quite surprising and quite enlightening is the results of knee replacement are as good as hip. In fact, we've got about 1/2 of the number of poor scores, so 2.9% poor scores at 6 months for this technique versus 10.9% for the knees versus 6.9% for the hips. And the excellent scores are the same as well. So we're managing to take patients into a hip-like level. I mean, it's always the holy grail for a knee arthroplasty surgeon, is to have hip-like results. And the other study we've done is we've looked at a group of patients where I was an early evaluator for tune, and we did 90 patients in the study, and there were 30 patients who were in quality varus who we put back to neutral. So we cut the tibia at 0, put the mechanical axis to 0, and then we compared them with a matched series who were in varus, and we put them in varus. And so we used the patient-specific cast balance technique, and we had 2-year prospective clinical outcome data. And what we showed is a significant improvement in the change in Oxford score, the WOMAC score, and the Cruise Sport score. And every other score were better, but not significant. It was small numbers. And of all those 3, the Oxford, the WOMAC, and the Cruise Sport score, they all reached a minimally important difference. So we've got a bit more just in the early evidence. I mean, there can be a lot of hearsay. We can all say how good our results are, but we really need to do proper studies to do that. And we've certainly got some evidence after 2 years. The other thing that's been quite encouraging is that when we track the 1 and 2 year data, there's quite a significant improvement there. So I think what these patients are finding is they take a while. I mean, any knee replacement takes a year or 2 to come right. And if they have a stable knee, they find they can do more between year 1 and year 2. So we're seeing about, depending on what outcome score you collect, a 2 to 4 times increase in the number of perfect scores between 1 and 2 years.
But would you accept this? These are some of the X-rays I came across in the lectures, and it's quite a bit of varus in the tibia there. My thoughts. For now, I'm sticking to mechanical alignment. I don't want to get carried away by kinematic alignment. Indian bones are softer, especially in patients with higher BMI, and excessive varus could lead to varus collapse of the tibial trays. Do not forget the art of ligament releases. I'm still comfortable with mechanical alignment and see no reason to change for now. I do not know what the future holds. I make minor changes in bone cuts to decrease ligament releases, but not leaning towards no ligament releases at expense of moving away from mechanical alignment. Patient satisfaction in my case is close to 92-93%. The single most effective change in patient recovery and better early results in my series is pre-op analgesia and continuous adductor canal block for 48 to 72 hours. Often I add mood elevators in certain patients who have a poor pain tolerance or are irritable from the start. No physiotherapy is being marketed by a lot of people, and I think you'll have more people walking around with weak knees tending to fall over and have disasters. And I am sincerely recommending all my patients to undergo physiotherapy for at least 2 weeks and continue the exercises longer. I do not know when I get access to robotic system in the future, whether I would experiment. I think I want to wait a little more and see the results globally and maybe then take a call. But for now, these are my thoughts. Thank you. Thank you very much.
Thank you, Dr. Vivek Allahabadia. It was a very comprehensive coverage and you have covered a lot of international talks also. So I have a few basic questions for you from our audience. I'll just stop your screen share.
Yeah.
So my first question is that you used to use a lot of navigation. In fact, I think all of your cases were navigation till 2 years back. Am I right?
Yes.
Yes. And then you gave up on navigation, saying that the robots will come up.
See, the navigation was a personally bought system, and I was losing in on depreciation, and I had reached a stage where I needed to upgrade it again. And I knew that robotics are coming in a big way, so I would rather invest in a robot than a newer navigation system. But the robotics are still quite expensive, so I'm waiting, seeing the results, and maybe we will adapt to the robot shortly.
So what I have also seen, what people advertise as robots are mainly advanced navigations. They are not actually real robots, except for the Johnson & Johnson, which is still in experimental stage.
Actually, the true 6-axis robot, which is launched by Merrill, is totally autonomous, and you can dial in your values very accurately. And people who are moving more towards kinematic alignment are debating about 1 degree change or 2 degree change. Not possible in navigation all the time, but in robotic it is very much possible. I still feel that it is more accurate and better than the haptic systems where the saw is used or the burrs are used. I've seen instances where people have demonstrated burr-based systems and the burr gets heated up and they have to stop. Sometimes I've seen them complete surgeries with saws. I've had a demo of the autonomous system and I've seen a couple of live surgeries. The autonomous system is really going to change things. There are some robots where the robot just places the jig onto the bone, and you still have to use jigs. In some, it is a saw. You don't have jigs. But I think the autonomous 6-axis robot is the best just now. And people who really want to get into kinematic alignment, where every degree matters, they want to be very accurate. The autonomous robot would really give them that kind of delivery.
Okay. And so you have been using navigation, and now since last 1 or 2 years, you don't use navigation. So have you found any difference in the surgical or post-operative patient outcomes?
So in patients with femoral bowing, tibial bowing, initially with navigation, it is very fluid. It's all part of your pre-op plan as you morph the joint and you put in your data, and everything is automatically calculated and you get a mechanical axis right. Now I have to do a lot of pre-op planning and manually decide my varus valgus cuts. So, I mean, I'm managing, but that ease of effortless things. Plus, sometimes you get patients with femoral nails where you don't want to do intramedullary intervention in the form that remove the nail and then do the second surgery for a knee. So we've done quite a few patients with implants inside where we managed to do external morphing and with navigation give them a knee without them undergoing an implant removal. Then managing deformities to a certain extent intra-articular is very well done with the navigation system.
Okay. So you still will recommend navigation for people who are basically doing regular joint replacement surgeries, that navigation still helps and makes your results better?
I would say that navigation is a good tool to have for difficult cases. I wouldn't recommend everybody to go and buy a navigation system. But do full length x-rays, don't be caught off guard where the patient has got both femur and tibia and you're looking at short films and doing standard cuts. So you may need to modify your cuts based on the long leg films. Yeah, but for complicated cases, I think the ideal scenario would be that the surgeons get access to a navigation on hire for difficult cases. I don't think it's worth investing. The technology is changing too fast. Navigation for now will die a gradual death. It will only be robotic surgery in the future.
Okay, and you're talking about the post-operative, pre-operative analgesia part. So can you just brief a little bit on that? What is the pre-op analgesia and what is the intra-op and what is post-op? What have you done differently?
So in the pre-op, the night before the patient gets, I usually give them etrocoxib and gabapentin. Patient should not have sleep apnea or morbidly obese patients. We avoid gabapentin. And during the intra-op period, non-diabetics get 1 dose of 8 milligram DEXA. This is my protocol. And intra-op, we do local tissue infiltration before cementing the components. And post-op, now we are routinely, we have access to an ultrasound machine in our operation theater. So we put in a adductor canal catheter and connect it to a Baxter pump, which we keep refilling, adjusting the dose. So patients are really comfortable. It's a beautiful system because it's a pure sensory block and the patients can start walking in 12 to 14 hours. And since we've started using continuous adductor canal blocks, a patient recovery is very, very good. We hardly need 10 days of physiotherapy at home. Most of the work is done in the hospital. Patients are going home with lesser analgesics, lesser need for pain medication, and I compulsorily give physiotherapy for 10 to 15 days. There are a lot of patients who do not comply. We do not know what happens, and then they come back with stiff knees, which is, some come back with a mild flexion deformity, some may get stuck at 70-degree of movements. So I make sure that my patients are not having any deformities and, due to lack of physiotherapy. So yeah, since I've been using these things, my patient satisfaction and is better. Patients are recovering faster. They are happier. Even the bilateral knees are recovering quite fast. And, they're getting independent within 2 to 3 weeks.
Okay, I think that's all from our side. We thank Dr. Vivek Allahabadia to spend time with us today evening. And we thank all our audience to spend time with us every weekend. This is the longest running series, the OrthoTV original webinar series on OrthoTV. Thank you, everyone, and good night.
Thank you. Good night. Bye.
Bye.